good afternoon to you, ladies and gentlemen, and a warm welcome from Cape Town. I use this term warm welcome advisedly because outside it's 36 degrees Celsius. I think of some of my poor colleagues playing golf. They're slaving away over a hot course. And here we are, nice, cool air conditioning rooms with Steve's minibar. It's wonderful that we can be cool and our poor colleagues are slaving away outside in this 36 degrees heat. But to all those people that are with us, and there's many hundreds that have logged on from far and wide, we say welcome to Cape Town. And this week, ladies and gentlemen, we are sponsored by the Pelvic Floor Foundation of South Africa. And the topic is, as you've seen, a slightly different one as advertised. Steve, can we share slides?
Your slides are ready.
My slides are ready, yeah. So what we're going to do then is have a talk on the menopause and the pelvic floor. This particular talk, I will be presenting myself, and anybody that wishes at any stage to interrupt, I'll be delighted to take their questions. The talk next week is the bladder, overactive bladder, and the topics of the overactive bladder, and that is sponsored next week by Astellas Urology. And as I say, this week's talk is sponsored by the Pelvic Floor Foundation. Steve?
Excellent. Yeah, excellent. So yeah, well, it is a great pleasure to have Pete. I mean, isn't anyone more qualified to give a talk on this specific topic, the effect of menopause on the pelvic floor, and without a doubt, you know, a very important issue. We know that these issues emerge quite you know, very commonly in menopausal women. So but thanks so much, Pete. I mean, Pete really is considered to be the great-grandfather of urogynecology in South Africa. So
the great-grandfather.
Yeah.
I thought I was just the
grandfather.
So
anyway, yeah, so please go ahead, Pete. And
yeah,
look, we might there might be a bit of a delay on seeing some of the questions, but fire your questions away on the chat because we actually on one computer, yeah, so we can't actually really maybe get some of the questions, but fire away and we'll try and catch some of the questions as we go along.
Right. And a special thank you then to Ashley Murray, who's our technician this afternoon of the Pelvic Floor Foundation. Thank you, Ashley, for assisting. Now, Steve, in the past, we always talk about menopause and the effect of menopause in the cardiovascular system, which is indeed a very important topic. We speak about menopause and the therapy for menopause, but we have not yet to date in this forum mentioned the effect of menopause on the actual pelvic floor. And for that reason, I'd like to just say a few words about this topic. The next slide will show that the disclaimers, and Steve, if you can bring up the next slide, please. Yep, there we go. Disclaimers. There's certain images in this talk that are of a graphic nature. If you're likely to be offended by graphic and explicit pictures, please leave the presentation at this point. I don't have any disclosures, and the sponsor this afternoon is the Pelvic Floor Foundation of South Africa. So menopause and the pelvic floor, Steve, the new term since 2014, remember we used to use the word vulvar-vagina atrophic vaginitis or senile atrophic vaginitis, but these figurative terms are no longer applicable, and the genitourinary syndrome of the menopause is the new term introduced in 2014. It encompasses all symptoms of the woman's pelvic and reproductive organs, but also the bladder and urethral tissues. And that's why the genitourinary syndrome is much more appropriate than the old atrophic senile vaginitis of the past. So this new term will be used from now onwards. So Steve, if you can just show me, there we go. And it starts with some pathophysiology. The pathophysiology of this presentation is that the estrogen receptors that are distributed widely throughout the pelvic floor, and these estrogen receptors are found in all the reproductive organs, but also the bladder and urinary organs, as well as the pelvic floor muscles and fascia. So withdrawal of these estrogens in the absence of hormonal therapy has profound effects. Now, if you have a look at the bottom two slides, on the left-hand side, we have a 38-year-old woman. She's got some prolapse, and her symptoms were those of prolapse and stress incontinence. Note the appearance there. Fast forward 40 years, and you have exactly the same woman 40 years and on, and that shows what the effect of withdrawal of estrogen on the pelvic floor and the genitourinary organs are. So you must remember that there's a 95% decline in estradiol levels postmenopausally. And these incredibly slow declining, but nevertheless inexorable decline in the estrogen levels causes the hyperestrogenic changes, which we're going to address in the pathophysiology this afternoon. So the genitourinary syndrome of menopause develops gradually by thinning the superficial epithelial cells, specifically of the vagina, and that causes more vaginal trauma or vaginal trauma specific during intercourse and coitus. Also during exercise, and the effects then we will discuss. There's loss of rugae and loss of elasticity of those anatomical organs, with vaginal shortening and vaginal narrowing with very considerable effects. Now, as a result of the withdrawal of estrogen, what we have is an increase in the subepithelial connective tissue and the marvelous elasticity of the vagina, which is there premenopausally, is lost, being replaced with the connective tissue, and the vagina then changes in character as a result of the menopause. There's also a reduction in the vaginal secretions, and that causes dryness. Now, the dryness isn't only apparent, Steve, menopausally, but also 85% of women over 40 years of age have some degree of dryness of the vagina, and that causes itching of the vagina and irritation. As a result then of the less estrogen, there's less lactic acid production by the lactobacilli, and of course that acid milieu of the vagina, which is so nurturing to the lactobacilli and the balance of vaginal organisms, the increase in pH during menopause causes an overgrowth of more common organisms one finds there, like Gardnerella, Streptococcus, Staphylococcus, E. coli and other coliforms, and Trichomonas. So these are the direct effects then of the withdrawal of estrogen, hence the old moniker menopausal atrophic vaginitis, the vaginitis implying infection with those organs that I've mentioned. So if we look then at the urinary tract, we must remember that the urinary tract itself contains many estrogen receptors. That's not only the bladder, but also then the urethra and allied organs. So the low estrogen affects the bladder and the urethra, but also the pelvic musculature, the levators, and the endopelvic fascia. So following on, you have symptoms of urethral discomfort. You have frequency of urination, sometimes hematuria, dysuria, and more common urinary tract infections. And it's because of the withdrawal of estrogen from the pelvic supports of the fascia and the levator muscles, there's more prolapse, there's more stress urinary incontinence, and more irritative symptoms of the bladder, like overactive bladder. So the next slide will then show androgens and the tissues. Now, there's also androgen receptors in addition to the estrogen receptors in the vaginal mucosa. Androgen receptors are also found in the muscularis of the vagina and the adventitia. So this, in fact, is the basis for people doing androgen therapy in menopausal women for maintenance of vulvovaginal health. Now, I must, at this point, while we're talking the pathophysiology, say that you mustn't think that testosterone gel is the panacea, because at the present time, testosterone therapy is not an approved South African therapy for this form of the problem.
Where do they put it in the vagina?
Well, there's different forms. Now, that picture over there is just testosterone gel, and that is not available. You can use it for men and for other things, but the andro gel that you'll see a picture of just now is the one that is available in other forms. It's available in South Africa, but only for men, and that's for specifically for testosterogenic effects. Now, I had a woman that couldn't say testosterone. She used to say testosterone, and I think it's rubbed off on me. But testosterone, Steve, is only at the moment in this country, South Africa, available for men, and that's for low testosterone conditions. So it's not the panacea, and women that use it in the vagina, again, it's very much off-label use.
Okay. And are you going to be talking about DHEAS?
Yes, that's an interesting one. We're coming to that later.
Okay.
DHEAS. What does DHEAS stand for?
Dihyperestrogen sulfate.
Exactly, Steve.
Do you know?
Dihydroepiasterone sulfate.
Steroid, maybe?
That's right. That too. So remember, there are many other forms of menopausal conditions. Now, oophorectomy is a common one. If a woman has an oophorectomy before the menopause, she can expect. This is usually done, Steve, in women that have breast cancer, and then they would have oophorectomy for that reason. But primary ovarian failure is also a cause. It happens also in, for example, radiation. Pelvic radiation causes primary ovarian failure. Chemotherapy, I've seen, cause primary ovarian failure, and uterine artery embolization causing primary ovarian failure. So these interrupt the blood supply to the actual ovary with catastrophic results. Anti-estrogens like tamoxifen for breast cancer, danazol, medroxyprogesterone acetate, MPA, gonadotrophin-releasing agonists, and also antagonists, Zoladex. Those also cause primary ovarian failure, and these cause then reduction in the estrogen effects. Postpartum, when that placenta is delivered, the estrogen level in the woman falls precipitously. And why would the estrogen have to fall? Well, that starts the, as we know, lactation. So it's like a switch. The thing that switches on lactation is reduction in estrogen levels. Unfortunately, while it's great to have lactation, it also does cause in this postpartum time thinning of the vaginal effects. And that women, some of the women, not all by any means, some women have then a vaginal atrophy that's akin to menopause and causes dyspareunia.
Yeah, absolutely. I mean, in the UK, we used to use a lot of the local estrogens for patients who are breastfeeding with atrophy. So it's actually quite a useful thing to give. The only point about that is if you do prescribe patients your Premarins or something, remove your package insert, because it actually says you shouldn't be giving it to breastfeeding patients.
Well, you see, that's the problem. We're coming to that again just now. You shouldn't read and believe everything you see in a package insert, more of which are none. But connective tissue disorders also I've seen. You saw just now a picture of the woman with the procedentia, and you come again to it. And this was a woman with a connective tissue disorder. She was, in fact, not even 50. And her connective tissue disorder caused procedentia. The problem there, of course, is not much you can do about it, because the connective tissue disorder causes the prolapse, and the treatment then, well, you can try treating the connective tissue disorder, but the treatment then would obviously be hysterectomy. So that's SLE, rheumatoid arthritis, and also glucocorticoid. Steve, if you can call up the next one. There we go. So genitourinary syndrome of the menopause is a better descriptive than senile atrophic vaginitis or vulvovaginal atrophy. Now, one of the things it causes, we've spoken about in the pathophysiology, the vagina and the vulva. The uterus too then suffers, because you get thinning of the lining of the uterus. Up to a year later, you can get postmenopausal bleeding. And at the bottom, you see then an ultrasound scan of a very thin endometrium. It's 2.38 millimeters in thickness. And there's a hysteroscopy of the same picture. And that picture then shows then endometrial atrophy with bleeding then, just like you can get atrophy of the vagina and the vaginal epithelial tissues. The same thing holds true then for the endometrium. Yeah, the next then shows we've moved away now from the pathophysiology of the lack of estrogen, hyperestrogenic state. We go now to the history and the examination. Just look at that picture there, Steve. When we do the examination, you'd see there's a very thin, very uniform effect of the vaginal epithelium. You've lost all rugae, the rugerosity, the vascularity is lost. There's thinning atrophy then of the surface epithelium, and you can see the profound effects then of the hyperestrogenic state on the vagina during the menopausal status. If you can just change.
Yeah, and you can actually see she had quite a traumatic delivery before as well, Pete. I mean, you can actually see the previous effects of the episiotomy, and you know, that's obviously very apparently as well, which could potentially lead to some symptoms.
Absolutely. Now, here we go. In the first consultation with the history, we've done the pathophysiology, you get to the history in these women. General and habits. Smoking, then, we know as a general bad idea for vascularity universally in a woman, but certainly it holds true then for the vulvovaginal area. Medications and the medical conditions we've mentioned already. Surgical conditions are also often devascularizing of that area. We come to that. You take a gynecological history, of course, an obstetrical history, the surgical history. You must ask about incontinence of not only urine, but also feces and also prolapse. Now, in the history, having gone over those things, we look at now the general gynecological exam. We start in the sequence: external genitalia, then the vagina, and then the rectal examination. So starting with the external genitalia, the next slide will show, when that comes up, this is a woman that came over here with symptoms of vulvovaginal atrophy, but just looking at it, just glancing over there, you can see that she's got this very, very severe and profound abnormality of the skin. I did a resection over there, and that happened to be VIN3. And you can see then the other things, you have to keep your mind open as to other causes, not only atrophy, it's also other pre-malignant conditions. So those must be biopsied, or in this case, excised, and that then showed a rather large VIN3, which then has to be addressed as a standard part issue. Now you've seen this picture, you've seen over here on the left, this is a young woman, but she does have prolapse. She's got no atrophy. Notice then the quality of her tissues, they're very well vascularized, there's no thinness, and you can see, if you look carefully, the rugosity of the vaginal architecture. She also happens to have a large cystocele and also very large genital hiatus. So move forward 40 years, Steve, and you would see then, no, I didn't mean move forward the slide, Steve. I mean, move forward, just go back the slide, Steve. Steve's move forward to the right-hand picture is what I meant. You'd see 40 years later, moving on 40 years, you would see then that the vagina, it's almost like our Photoshop, but it's a different patient. You can see that the rugosity is lost, the vascularity is lost. She still has a very large genital hiatus. The beautiful turgor of the vascularized, estrogenized tissue is also diminished. And over there, you'd have to do then some form of hormonal replacement then to try to alleviate her symptoms. All right, now move forward, Steve. There we go.
Click yourself, man.
I can click myself now.
Yeah.
Just there.
Just click there.
All right, now look at these external genitalia. This is the vagina. There's atrophy over there. Not only has the atrophic tissue caused scarring, and notice then that the genital hiatus over here has been completely reduced by scarring. And then that tissue at the bottom there, at the fourchette, just above the anal margin, you can see that's grown. It's thin. It's terribly, terribly friable. It's very painful. It's lost its estrogen, and that causes severe dyspareunia. As a woman that got married late in life, she came to me and she said, what are we going to do? Well, many people would say use dilators. But personally, Steve, you know, I'm not a person that would go there. I would rather go the surgery route in this case, because although the dilators would work, you don't know how long they've got, they're very painful in a woman like this. And then I went the Fenton's route, and you can see then by doing a Fenton's operation, you've opened up the vaginal introitus. It's still atrophic, obviously. You're going to have to use then menopausal therapy, same woman, but when that's healed up in 2-3 weeks' time, you can start your Premarin or your Vagifem, and then she can carry on. It would be very, very advantageous then to keep going with that form of hormonal therapy.
So, Peter, I think, I mean, those patients, Premarin is definitely a better option. I mean, I think the Vagifem may not get to that whole area. I mean, if you just want to go back, I mean, you can actually see this is very externally very atrophic around here.
It is.
So I would actually almost say to this patient, take some with a finger and put some around there.
Good idea, Steve.
Yeah, but yeah, because I don't think the Vagifem is really going to touch size on that patient.
Right. All right, next one.
Yeah. Keep clicking, Pete. That's it.
There it is. All right, now we go off the external vulva, and we go down to the vagina. Now, Steve, yeah, you can see us looking at the vagina. We look at 3 of the compartments. Remember, I said you could have the 3 compartments of the vagina: the anterior, the apical, and the posterior compartment. Now, the mid compartment over there is best examined by means of sim speculum. Now, you might not have sim speculum. I know a person like you, the professor of urogynecology, certainly has. You probably have lots of sim speculum, but an average jobbing vulvovaginal urogynecologist might not have access to that. So what you can do then is you can make your own sim speculum by taking the usual plastic and dismembering that. Then you've got an anterior and a posterior. And just by taking that apart like that, then you can do a very nice vaginal examination and see. And you actually have to have a sim speculum, because while a Cusco speculum is very good and very nice and very handy, you actually have to see which compartment is actually prolapsed. And then also inspect that compartment, look at the character of the tissues, look at the size of any prolapse that is available. And you would see then, if you see that bulge, is that a cystocele, or is that the mid compartment, or where is it? And if you're going to do a surgical repair, if that's causing trouble to the poor woman, you can actually do the wrong repair and approach it unless you know exactly which compartment, with the size of the repair and the extent of the repair. Now, not only I'd say that's the mid compartment, and that would mean that you'd have a completely different approach to a woman that has an anterior or posterior prolapse. It's again thin. Notice you've lost rugae, you've lost a little vascularity over there. This is an older woman, and she will, in addition to need some form of sacrospinous or even laparoscopic sacrocolpopexy, she would have to have a vaginal repair with the replacement of her estrogen in that case. That likely too is a mid compartment. And although it's easy under those circumstances to say, oh, you don't need some speculum over there, you don't always. But if it was a smaller prolapse, as the first one we saw, you would definitely need a SIMS and examine that area then by means of a SIMS speculum.
But the thing I like to do with the SIMS is push that prolapse back and sort of get the anterior compartment, nicely reduced, and get them to cough. And you can actually see if they've got a little bit of stress incontinence as well. Because just fixing the prolapse might unmask some stress incontinence in those patients, and you might then indeed get, unhappy patients who develop stress incontinence after the operation. So, just
absolutely, Steve. Yeah. Now, talking about pushing things back, I was a woman. She was premenopausal, in fact, and she presented. She has a connective tissue disorder, but she also, as you can see, a complete procedential eversion of the uterus. Now, before you can just push it back, what I did over there is I always put some lubrication, in this case, some topical lignocaine gel onto the uterus. And you can see it's looking, there is a bit of a glance over there, and that shows that she has had some lubrication. And also it's anesthetic. So when you reduce that, it's not so painful and it's much more comfortable. So you have to reduce it. As you say, you don't know what lurks behind that, Steve. So not only must you say reduce it, but there might be, it's like if you're going to drain this, you're looking for the alligator, you actually have to drain the swamp. So over here, if you put on your anesthetic gel and you reduce it gently and kindly, what do you see? There's a very large prolapse of the urethral mucosa. And so not only must you reduce the uterus, you must also see what lies behind it. And over there, if you hadn't reduced it and just gaily surge into surgery, you'd miss that completely. And you'd only spot that after you've removed the very large procedentia. So this enables you then to reduce the procedentia, and she can then give topical estrogen. What would you use for that urethral caruncle, prolapse of the urethral mucosa?
Yeah, I would. I think estrogen's a good first start. It is difficult. I mean, if they're really big,
that is big, that one.
Yeah. Whether you go in and resect them, I think you maybe need to ask. I mean, I think I would advise most people to ask urologist to look at it if it is bleeding and causing a lot of discomfort.
Can it be resected?
It can, but I've had success with a big one like that I actually did. They aren't as symptomatic as one would think, and luckily we don't see such big ones. But I think estrogen cream is a very good place to start for most people.
I would.
What would you do?
No, definitely. That's what we did for us,
So
Steve.
would you cut that out?
No, I must say I wouldn't resect it.
Yeah.
I would give her the estrogen cream in this case, reduce that. That's what we did, Steve. In fact, we gave her the estrogen cream, and you might not remember her, but you and I did it together. We removed that uterus, and she's now very well apart from her stress incontinence. Yeah. And you're going to fix that, aren't you, Steve?
Yeah, we're going to fix the stress incontinence. Well, that was the whole point, I mean, she's got a nice reduced prolapse now, but she developed stress incontinence, and they don't really like it. So I think it's good to check to see what you've got before you do surgery like that. So
yeah, unfortunately, whether you like it or not, when you have huge prosthodontia like that, we did it vaginally with a sacrospinous. It worked very nicely. The stress incontinence came. That was always going to be an issue. You can fix the stress incontinence in Shubianki Dori. So she'd be very happy indeed. Now, we've mentioned then the vulva, the external vulva. We've mentioned the vagina. And now we actually have to get onto the bladder and urethra.
Just to say to everybody, you can ask some live questions. We can actually look at the questions. So if you've got any questions, fire away. We've got a way to look at the questions as well.
Okay, thank you. Ultrasound scan of the bladder. Well, it's about the only way really, apart from looking at the cystocele, how you're going to see the bladder, its function, its size, and its capacity, and most importantly, its post-void residual. And this is an exceptionally easy thing to do. And it's most important also when diagnosing the cause of incontinence. This is a woman that has overflow incontinence. And when you see that, the very best thing you can do is ask the woman to empty her bladder and then repeat that, because in this particular case, you can measure the post-void residual. There's the formula you do. And this picture over here shows she has emptied the bladder, and unfortunately, she's left most of it behind. So this is definitely a case of overflow incontinence. And overflow incontinence, one of the causes obviously is the menopause. It happens much more likely in menopausal women. They can't void because the detrusor has been chronically overstretched. And over here, in this case, sorry, the great joy of this is that the woman can be offered self-intermittent catheterization, and not indwelling, but self-intermittent catheterization twice or 3 times a day, and she'll be absolutely dry because this very large bladder then contains the urine and doesn't allow overflow incontinence. Previously, she was wet as a drain, and then after the self-intermittent catheterization, 3 times a day, she's dry. Unfortunately, this isn't always easy if the woman is really elderly and she has poor hand-eye coordination or arthritis. Under those circumstances, what would you do?
Yeah, I mean, I must say the very old patients with chronic voiding dysfunction, suprapubic catheter often works very well. I've got a few really old patients in the 80s and 90s who just really wet. It's a problem for their carers, and often the people are taking them in out of bed like 4 or 5 times a night.
Wow.
Sometimes they can even control the suprapubic catheter themselves. You give them a little valve, and they quite like it. It sounds like a really invasive thing to live with, but if that's the other option, rather than being wet, it's a good option.
Steve, now the obvious question that begs itself over here: what about surgery in these cases to reduce the bladder volume?
No, I mean, remember, Pete, this is actually, it's a bladder failure problem, almost like intrusive failure. I like to, you can almost use the analogy of a heart failure. And the only thing that could really work would be a bladder transplant. But,
yeah,
we haven't got there yet.
No, I don't think we're going to get there in my lifetime, Steve, maybe your lifetime, but certainly not. And also, as you say, surgery is not indicated over here. Rather have a carer. If you, a woman in an old age home, or mature women's home, as we call them nowadays, you can get maybe a carer to do the catheterization. It only takes 5 minutes, and it allows her then in between times to be absolutely continent. So if she can't manage, perhaps she's an institution, and it's not difficult. Some woman that's adroit and dexterous can do that for her, and she's absolutely happy as Larry. Yeah. Okay, now let's move into the final thing that you need to do is the rectal squeeze. The rectal squeeze, you check the integrity of the anal sphincter, and also enables you then under these circumstances to have a jolly good look if she has a rectocele, to assess the character of the rectocele. Now, we haven't mentioned therapy yet. We've spoken about DHEAS, which happens to be dihydroepiandrosterone sulfate, Steve. That's what it is.
Okay.
I Googled it. So here we go, therapeutic options. The first thing is for mild dryness or mild discomfort, you don't actually have to start with estrogen. You can also go for non-hormonal vaginal moisturizers or lubricants. Now, there's many on the market. I took a stroll down Discam outside over here at lunchtime, and I found that there's a whole aisle dedicated to various forms of vaginal moisturizers. Some are more expensive than others. This is just an example. I'm not in any way advocating this particular product, but it's just something over there that is classed in the non-hormonal vaginal moisturizer. You buy it over the counter. You can use it whenever you wish, And for very mild and transient cases, this would be the right thing to use. Some of them have hyaluronic acid, and that's another tongue twister, hyaluronic acid. And this particular one doesn't. The people that do market it with hyaluronic acid say it's very good for you, but I'm not sure if vaginal moisturizer should or shouldn't have that with it. Now, if this doesn't work, or when this doesn't work, the next would be the topical vaginal estrogen. And the advantage of topical vaginal estrogen, Steve, is it can also help urinary symptoms, particularly irritative symptoms. So if a woman has symptoms of overactive bladder, and this thing doesn't work, which it's not going to work for irritative symptoms, the next step is for the woman to try topical vaginal estrogens. And that would help her symptoms of burning, itching, tissue fragility, and even dyspareunia. So the vaginal estrogen is used then for the GSM. And how does it work? It restores the vaginal acidic pH and the microflora, so it allows then the lactobacillus acidifying, producing the microbiome to flourish. And that, of course, then improves the vaginal milieu. It thickens the epithelial layer, increases the vaginal secretions, improves the general symptoms, and has urinary tract benefits of the irritative symptoms, which is overactive bladder, and also might even reduce the incidence of urinary tract infections. Do you think it does?
It's very important.
Yep.
Peter. It's I think it can't be it might be one of the most important points you make today. It's markedly underutilizing patients with recurrent UTIs. It has a effect, as you said on your screen here, making the pH more acidic, and that is due to the increase of the glycolic acid and the glycogen production, and absolutely makes the biggest difference to patients with recurrent urinary tract infections. So it has to be started, and it's amazing how little it is used in many patients like that.
No, I agree 100%, Steve. Now, that one over there, the picture you see, there's Vagifem, 10 micrograms. It used to be a higher dose. They reduced its dose. It's even useful in women that have breast cancer. Now, marketers are very strange things. Those reps that were here in my office a couple of weeks ago, they just go back, Steve. They were telling me, yeah, those ones. They said, you can't use that stuff that's got estrogen in because it's got a black box warning in the United States. Now, although Fertimus and the other vaginal moisturizers don't have black box warnings, they don't have the estrogen, so they're probably not as effective as something like Vagifem. And there are many on the market, estrogen types. That is just one I'm showing over the Vagifem, and there's certainly, as we in South Africa feel, there's no increased risk of breast cancer or endometrial cancer, no increased risk of CVS, of stroke, or venous thromboembolic phenomenon. So we say you can use Vagifem. Initially, you'd use it more often, then you'd settle down to 2 or 3 times a week. And that is, as it says, it's marketed by Nova, but I do not punt it as a product. I'm just doing it over there by way of illustration.
So, Peter, are you saying that it's quite reasonable to start in the patients with the previous risk of, with previous breast cancer? You don't think it's necessary to talk to an oncologist? You can just willingly go along and
Steve, I definitely would. I'd speak to my local oncologist, and there's a few local oncologists over here. I think it's prudent, and excuse me, I think it's prudent, and I also think it's polite and apposite to give them a ring, drop them a line, and say,
would you mind? These patients are indeed being followed up by an oncologist, and it's quite nice just to give them a call and say,
I think that's.
Or the patients have often been advised to start it anyway. So
don't be rude and start it without their knowledge, because then it can just make your name mud. So do that. Let them know, and then start it, and it's wonderful stuff. And most women would appreciate the improvement in the quality of life, and I think it's well worth it.
Do you start it on a daily dose for 3 weeks and then go to twice a week dose? Or
I do. That's exactly what I do for the Vagifem. GSM options, well, conjugated estrogen cream for atrophy. Now that's called Premarin. Again, I don't endorse the product, although I've mentioned its name. It's very, very widely used. The other types, Steve over here has done He's done other forms of research. What's the other one called, Steve?
Well, I like the estriol, which is menopause. It's a good treatment. It's maybe slightly safer in patients with breast cancer because it doesn't cling to the nucleus as long as the estradiol, which is the Vagifem, and it's it's maybe a little bit more natural. I mean, if you look at that big cascade that you all learned about in part one, you'll see estriol is actually a natural estrogen, whereas estradiol doesn't actually feature in that. So it's a synthetic one. So yeah, I mean, I like the estriol and the sinopause, but I can't find sinopause. I mean, it's very difficult.
I was going to say,
yeah,
if you can find it, it's rare as hen's teeth.
Yeah. Are you going to talk about the ring because it's not available anymore and stuff?
No, that's why I'm saying the other things that aren't available and some things that aren't actually allowed, they are off-label use. So for that, I just mentioned there in passing that the other ways of administering estrogen, but the ring isn't one of them nowadays. It's very important, Steve, to realize that sexual abstinence or coital abstinence increases atrophic changes, and conversely, intimacy increases the vascularity of the vaginal lining, and that epithelium improves in elasticity and in health by means of intimacy. And if a woman, unfortunately, is still smoking at that age, it reduces her vaginal perfusion and makes things worse. And sometimes the other thing that is a problem in intimacy in menopause women is, I see this occur often, a woman that has very profound and extensive stress incontinence, they have excoriation of the skin.
Absolutely.
And they also have excoriation by using pads and nappies. So under those circumstances, before you're going to do anything else and suggest intimacy, you've actually got to cure the incontinence.
Yeah, no, absolutely. It's
if you
it's a real
can.
problem. Yeah, and it actually can exacerbate the recurrent UTIs as well. So often you get a patient who's got stress incontinence or incontinence and recurrent UTIs, and you really need to get that incontinence sorted out and then the atrophy too.
Yeah. Okay, let's move on from intimacy. Now, here's these other options you mentioned. Now, as I say, they're off-label in this country. They might not be off-label in Australia and in America. But the DHEA, Steve, what did you say it stands for?
Dihydroepiandrosterone sulfate.
That's the word. So I Googled it, dihydroepiandrosterone sulfate, and that's also called prasterone. It's FDA approved, would you believe? And it's approved in America as a daily pessary for dyspareunia. It's not approved over here. Steve, you were at the recent menopause meeting in Stellenbosch, as was I, and we heard glowing reports of the use of vaginal DHEA. And this was used by many people on extensive use. But although it might be used by sexologists and other people that deal with these problems, menopausal women therapists, I do caution that it is off-label use and it must be approached in this.
Where do you get it? Do you make it? They get made up at these compounding pharmacies?
You do. There is a famous one, and I won't mention its name again. I really won't mention its name. And you can buy it online as well, Steve. We had that Italian that spoke extensively and glowingly and lovingly about DHEA, but although it is available online and also in a compounding pharmacy in Cape Town, it's not available in the shops because it's off-label use, and it's not available because
very expensive.
I've no idea at all.
I haven't been writing it up, but I know some of my colleagues do. So
yeah, very widely. If a woman turned up and she was using prasterone, which is vaginal DHEA, would you continue it?
Absolutely. Why not? I mean, it's normally written up by someone who's had a reason to write it up, and I mean, obviously you need to use the mainline stuff first. I mean, I would always think about a steroid, the estrogen first, but it's normally been written up by someone who's got a contraindication, or what would be a contraindication for the DHEA?
I'd say its only side effect is poverty because it's so expensive.
So I mean, if the patient doesn't really want to have it, I don't know if it works in a patient who hasn't had a response to the estrogens. Yeah.
Okay, well, you gave the talk on vaginal laser. That's another option. It's not mentioned here because Steve is doing a talk on vaginal laser, but that is something that is used for vaginal atrophy or vaginal atrophy. So it's a non-medicated option. It's a physical option, but it is available, ladies and gentlemen. So then ospemifene, it's an oral SERM which is FDA approved for vaginal atrophy use. It's not available, so I'm just mentioning over here for completeness sake. And then, as I said, androgel is available in this country. It's marketed over here extensively for men, and it's used transcutaneously. It's used for men that have hypotestosteronic testosterogenic conditions.
Okay.
That's
Good.
not you.
Yeah.
So it's not used over here, testosterone vagina, although I know that that particular sachet you see over there, it can be used in other countries vaginally in small doses. Not a whole one, but just 1/10 of one, Steve.
Yeah, but I mean, we do use that androgel for other things like libido, hair loss.
Androgel?
Yeah.
Libido?
Well, I mean, it's not obviously
In men or women?
In men, I mean, in women.
Oh.
But I think for hair loss, it can actually.
In women?
Yeah.
Hair loss in women?
Yeah. You obviously need to, I mean, I'm not an expert in this, but I have actually been advised.
Androgel, they're going to put on their scalp.
No, I think if you do it in a controlled fashion, make sure you do regular levels, and at a 10th of the men's dose. So you need to take that sachet and put it into a small syringe, and then they dispense 1/10 of it every day.
But where?
Onto the skin.
Of the vagina? Or
No, just on the normal skin.
I must say, Steve, you're teaching me things. I've never known that androgel can be used for hair loss in women.
Yeah, so I did have one. I mean, sometimes it's a very frustrating, debilitating, to a certain extent, problem in some patients. And yeah, but it obviously needs to be done under controlled conditions, and you need to check the levels, and maybe speak to an expert before you do that as well. Yeah.
Well, there's our Larry over here that does hair transplants, so that's another option.
Yeah. Moving on to just another question by anonymous attendee: can Vagifem be used with a patient with a kidney transplant with a recent UTI?
Vagifem.
Yeah, kidney transplant.
That's estrogen. Of course it's safe. Yes, by all means.
Yeah.
Sorry, I thought you meant androgel. No, Vagifem can be used, certainly. You'd agree with that?
Absolutely.
Absolutely. Okay, Steve, we've got another 10 minutes. So this brings us onto the subject of surgery. Where do we use surgery in GSM? Well, about the only place you could use it then is for prolapse accompanied by GSM. And there, as you know, you do extensive surgery. I assist you, as can be seen over there, the two of us doing surgery.
Yeah. Which one is you?
The handsome one.
Okay. Right. So you want to move on from this picture?
Move on from that one. Now, I'll tell you why I showed this picture, Steve, because unfortunately, and I say the word advisedly, unfortunately, the use of mesh in the pelvis is now restricted extensively because of class action lawsuits, and it's happened in this country as well. The only place we can use it, the only place it's available, in fact, is for stress incontinence and for apical vault prolapse in cases of sacrospinous and maybe sacrocolpopexy. Do you know anywhere else you can use it, Steve?
No, I mean, so it's restricted to, well, I mean, the only products that are available is the sacrocolpopexy mesh and the TVT sling.
Yeah.
I don't see that changing much in the future. It's, very well established by evidence and by all the bodies except for in the UK and in Australia, where it's, not really used at all.
Is that because of the guidelines, or is that because of the lawsuits?
Look, I mean, it's complicated in the UK. It's because we all know that all started with the politician stopping the use of the TVT in Scotland. I think that was already like in 2014. And, I never think they really managed to recover from that. And I think the politicians have, really stuck their heels down with this. And, the doctors and the NHS has made it very difficult for them to do TVTs. So that it's become very frustrating for patients. And in fact, I've had a few patients visit South Africa and have TVTs from the UK.
Next Monday, we're doing one together, Steve.
And advised by their doctors in the UK to come to South Africa if they come to South Africa for a TVT. So
come to Professor Jeffrey for a TVT.
It's not evidence-based in any shape or form.
What? TVTs are evidence-based.
No, the restrictions.
Oh, the restrictions.
So, and they do it all over the world. They do it in the UK. They do it in the US. They do it all over France, Europe. It's, so it's a weird situation they find themselves in. And in fact, one of my patients was advised she could have a fascial sling. if she wants to do a treatment for stress incontinence, which you all know is not a good operation at all. So
when I was a registrar, we used to do fascial slings.
yeah, it's a messy operation where you have to do a big abdominal incision just to cure someone who could be treated very nicely with a simple TVT.
Okay, Steve, I don't want to get off the topic.
Yeah,
So what I'm going to
completely
do is we're completely off piste here.
Oh,
I'd
we're
like,
done.
yeah, we're done,
Oh,
Steve.
yeah.
I'd like to thank you very much indeed.
No, we'd like to thank you, Pete, for that. I mean, very nice, lots of pearls from a lifelong career in seeing patients like this. We do have time for a few questions. I don't know if anyone wants to fire away at anything. If not, we can call it a day. And thanks so much for everything. Thanks to Ash for again with time in preparing these webinars. And yeah, is there anything else?
Steve,
You're
yeah.
not going to play off with one of your videos that you.
I beg pardon?
You're not going to play off with one of your videos, or
No, I'm not going to play any videos.
Holiday pics or something. No?
Yeah, my last holiday pic of my honeymoon in Mauritius 25 years ago. No, I'm not going to play out with that because I think my wife is watching, Steve, and I do want to live at home. And I'd like to thank you and the Pelvic Floor Foundation for sponsoring this. And we look forward, ladies and gentlemen, to a presentation next week on overactive bladder. It's being presented here by Professor Steve Jeffrey, and it's being sponsored by Astellas Urology. Yeah. So, Steve, thanks once again for the use of your facilities. And we look forward very much next week. We will be having a break. People have asked us if we're going to be breaking over Easter, and there will be a short break over Easter. Until next week then, safe home, all the very best, and good night.
Thank you.